Good evening, doctor. Tonight I am going to study acute heart failure. My reference, as always, is Tintinalli's Emergency Medicine. Acute heart failure covers a wide spectrum of illness, ranging from a gradual decrease in leg swelling, shortness of breath, or decreased exercise tolerance to the abrupt onset of pulmonary edema. While alternative terms such as decompensated heart failure, acute heart failure syndrome, or hospitalized with heart failure have been used nearly interchangeably, patients with either an acute exacerbation of chronic heart failure or a new onset heart failure are what we qualify as patients with acute heart failure. The term congestive heart failure is outdated and describes patients with signs and symptoms of fluid accumulation. Most visits in the emergency room for acute heart failure result in hospital admission. There's an increase in survival from acute myocardial infarction with an aging population and evidence-based outpatient treatment options, so the prevalence of heart failure is expected to increase. Long-term heart failure management has improved through the use of beta blockers, angiotensin-converting enzyme inhibitors, spironolactone, and cardiac resynchronization therapy, but acute therapy is largely unchanged. These include nitrates, diuretics, and positive pressure ventilation, which is basically the same as in 1974. Heart failure has a poor prognosis, with approximately 50% of patients diagnosed dying within 5 years. Hospitalization also marks an inflection point in a patient's heart failure trajectory, with those hospitalized having a higher mortality than a matched non-hospitalized cohort. Heart failure is a complicated syndrome manifested by cardinal symptoms of shortness of breath, edema, and fatigue occurring from functional or structural cardiac damage, impairing the ability of the heart to act as an efficient pump. A clinically useful definition of heart failure is as follows: a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or ejection of blood. Dyspnea and fatigue are the cardinal manifestations of heart failure, which may limit exercise tolerance and fluid retention, which may lead to pulmonary and/or splanchnic congestion and/or peripheral edema. There are responsive adaptations in the kidney, peripheral circulation, skeletal muscle, and other organs to maintain short-term circulatory function. These responses may eventually become maladaptive and contribute to long-term disease progression and acute exacerbations. Threats to cardiac output from myocardial injury or stress trigger a neurohormonally mediated cascade that includes activation of the renin-angiotensin-aldosterone system, which is also implicated in hypertension, and the sympathetic nervous systems. Levels of norepinephrine, vasopressin, endorphin, which is a potent vasoconstrictor, and tumor necrosis factor alpha are increased. Although not measured in routine care, elevated levels of these hormones correlate with higher mortality. The combined clinical effects of neurohormonal activation are sodium and water retention, which is why there's fluid buildup and edema, coupled with increases in systemic vascular resistance. These maintain blood pressure and perfusion, but at the cost of increasing myocardial workload, wall tension, and myocardial oxygen demand. Although some patients are initially asymptomatic, a secondary pathologic process called cardiac remodeling begins to occur, even triggering more dysfunction. Natriuretic peptides are the endogenous counter-regulatory response to neurohormonal activation in heart failure. Three types that are recognized are the atrial natriuretic peptide, primarily secreted from the atria; B-type natriuretic peptide, secreted normally from the cardiac ventricle; and C-type natriuretic peptide, localized in the endothelium. Natriuretic peptides can cause vasodilation, natriuresis, increased levels of endothelin, and inhibition of the renin-angiotensin-aldosterone system and the sympathetic nervous systems. B-type natriuretic peptide is synthesized as N-terminal 3-pro-B-type natriuretic peptide cleaved into two substances, which is the inactive N-terminal pro-B-type natriuretic peptide with a half-life of approximately 2 hours and physiologically active B-type natriuretic peptide with a half-life of about 20 minutes. Assays for both of these are available for emergency use in other countries. Because elevated levels of neurohormones portend a worse prognosis in heart failure, their attenuation provides a basis for most chronic therapies proven to delay heart failure morbidity and mortality. These include treatment with angiotensin-converting enzyme inhibitors, angiotensin receptor blockers, aldosterone antagonists, and beta blockers. Heart failure may also result from pump dysfunction from acute myocardial infarction. A loss of critical mass of myocardium results in immediate symptoms. If there is symptomatic hypotension with inadequate perfusion, cardiogenic shock is present. And if we're going to review, that is the etiology of shock that not only comes from the heart, but also has a decrease in cardiac output, or rather an increase in cardiac output, and also an increase in systemic vascular resistance, as we mentioned during the stroke session. Heart failure may also result from pump dysfunction from acute myocardial infarction. I already mentioned that earlier. Acute pulmonary edema may be precipitous and is a clinical manifestation of a downward spiral of rapidly decreasing cardiac output and rising systemic vascular resistance on top of underlying cardiac dysfunction. Even relatively small elevations of blood pressure can result in decreases in cardiac output. Decreasing cardiac output triggers increasing systemic vascular resistance, which further decreases cardiac output. Acute pulmonary edema can present acutely with severe symptoms, and if not promptly reversed, it may be a terminal event. There are many cases of heart, or rather, there are many causes of heart failure, which we will tackle later. Patients can be categorized into 6 phenotypes to assist with investigating the causes and precipitants for the acute presentation, as well as directing initial therapy. Those with acute heart failure and hypertension often have a precipitous presentation and may have significant pulmonary edema and hypoxia. Symptoms may be due to fluid redistribution more than fluid overload, and treatment initially focuses on antihypertensive therapy. Pulmonary edema may benefit from non-invasive ventilation to decrease the work of breathing and avoid intubation. For heart failure accompanied by hypotension or poor perfusion without another cause, think of an ischemic or structural heart trigger creating cardiogenic shock. Patients often benefit from inotropic agents and invasive hemodynamic monitoring to guide other therapies. Patients with acute on-chronic heart failure tend to present with gradual symptoms and weight gain over days to weeks. High-output heart failure is distinguished by a relatively normal ejection fraction and is often caused by anemia or thyrotoxicosis. Isolated right heart failure is characterized by lower extremity edema and jugular venous distension, but with little or no pulmonary congestion, and the cause is usually from pulmonary disease, valvular diseases such as tricuspid regurgitation or obstructive sleep apnea. Heart failure is classified as systolic or diastolic by ejection fraction, which is normally 60%. Systolic dysfunction or heart failure with reduced ejection fraction is defined as ejection fractions of less than 50%. Mechanistically, the ventricle has difficulty ejecting blood, leading to increased intracardiac volume and afterload sensitivity. With circulatory stress such as walking, failure to improve contractility despite increasing venous return results in an increase in cardiac pressures, pulmonary congestion, and edema. Diastolic dysfunction or heart failure with preserved ejection fraction is characterized by an impairment in ventricular relaxation, causing an abnormal relation between diastolic pressure and volume. This results in a left ventricle that has difficulty receiving blood. Decreases in left ventricular compliance necessitates higher atrial pressures to ensure adequate left ventricular diastolic filling, creating a preload sensitivity. The frequency of diastolic dysfunction increases with age and is more common in chronic hypertension, which leads to left ventricular hypertrophy. Coronary artery disease also contributes, as diastolic dysfunction is an early event in the ischemic cascade. So common causes of heart failure and pulmonary edema include myocardial ischemia, acute and chronic, systemic hypertension, which we discussed in the last session, cardiac dysrhythmias, especially atrial fibrillation with rapid ventricular response, valvular dysfunction such as aortic valve diseases like stenosis, insufficiency, aortic dissection, and infectious endocarditis, mitral valve diseases such as mitral stenosis, mitral regurgitation, capillary muscle dysfunction or rupture, ruptured chordate and delay, infectious endocarditis as well. Prosthetic valve malfunctions, left ventricular outflow obstructions such as supravalvular aortic stenosis, membranous subvalvular aortic stenosis, cardiomyopathies, including hypertrophic, dilated, restricted, and acquired ones such as toxic cardiomyopathy due to alcohol, cocaine, or doxorubicin, or metabolic from thyrotoxicosis and myxedema. Myocarditis through radiation and infection may also cause heart failure and pulmonary edema, so do constrictive pericarditis, cardiac tamponade, and anemia. So classifications of acute heart failure include the following. Hypertensive acute heart failure have signs and symptoms of acute heart failure with relatively preserved left ventricular function. A systolic blood pressure of greater than 140 millimeters mercury, typically with a chest radiograph compatible with pulmonary edema and symptom onset of less than 48 hours. Pulmonary edema manifests with respiratory distress, rails of chest auscultation, reduced oxygen saturation from baseline verified by chest radiograph findings. Cardiogenic shock manifests with evidence of tissue hypoperfusion with a systolic blood pressure of typically less than 90 millimeters mercury. So I'm not really sure if the definition of cardiogenic shock that I gave earlier is accurate, so I'm going to double check that real quick. And cardiogenic shock has an increase in preload. So there's still a decrease in cardiac output because I said it was an increase before. What is increased is preload and afterload. Systemic vascular resistance is also increased. But basically the key here in cardiogenic shock is there's a decrease in blood pressure, there's an increase in preload, an increase in afterload, and there is still a decrease in cardiac output. Okay, let's get back. Commonly, patients with acute heart failure will present with dyspnea, which has a large differential diagnosis, including heart failure, chronic obstructive pulmonary disease, asthma, pneumonia, and acute coronary syndrome. Common causes of dyspnea include heart failure, asthma exacerbation, COPD exacerbation, pleural effusion, pneumonia or other pulmonary infections, pneumothorax, pulmonary emboli, physical deconditioning or obesity, fluid retentive states such as dependent edema or deep vein thrombosis, hypoproteinemia, liver failure or cirrhosis, portal vein thrombosis, and renal failure or syndrome. There are also impaired cardiac output states such as acute myocardial infarction, acute valvular insufficiency, drug overdoses or drug effects, dysrhythmias, pericardial tamponade, tension pneumothorax, high output states, sepsis, anemia, and thyroid dysfunction. So there's no single historical or physical examination finding that achieves both 70% sensitivity and 70% specificity for the diagnosis of acute heart failure. There's also no single diagnostic test for heart failure because it is a very clinical diagnosis based on both the history and physical examination. A history of heart failure is the most useful historical parameter, but it still has poor sensitivity. So risk factors for acute heart failure may be helpful, such as hypertension, diabetes, valvular heart disease, old age, persons who are assigned male at birth, and obesity. So the most sensitive symptom is dyspnea and exertion in 84% of patients. The most specific symptoms are paroxysmal nocturnal dyspnea, orthopnea, and edema. So precipitants of acute heart failure include non-adherence such as excess salt or fluid intake and medication non-adherence. Renal failure as well, especially patients with missed dialysis. Substance abuse such as cocaine, methamphetamines, or ethanol. Poorly controlled hypertension or iatrogenic cases such as addition of negative inotropic drugs like calcium channel blockers, beta blockers, initiation of salt-retaining drugs such as NSAIDs, steroids, and thiazolidinediones, inappropriate therapy reduction, and no antiarrhythmic agents. So an exam, an S3 sound has the highest. Sorry, needed to drink water. On exam, hearing the S3 sound and auscultation has the highest LR for acute heart failure, but its absence is not useful as a negative predictor. However, there is an greater reliability of the S3 sound, which is something we have to account for, and ambient noise in a busy emergency room may interfere with S3 detection. Abdominal jugular reflux and jugular venous distension are the only other two physical examination findings which have an LR plus greater than 5. Increased neck size, obesity, and rapid breathing may diminish the ability to accurately measure jugular venous distension. Chest radiographs showing pulmonary venous congestion, cardiomegaly, and interstitial edema are most specific for final diagnosis of acute heart failure. But the absence of these does not rule it out because up to 20% of patients subsequently diagnosed with heart failure have chest radiographs without signs of congestion at the time of prior emergency room evaluation. Particularly in late-stage heart failure, patients may have few radiographic signs despite symptoms and elevated pulmonary capillary wedge pressure. The EKG is not useful for diagnosis, but it can reveal an underlying cause of precipitant. EKG signs of ischemia, acute myocardial infarction, or dysrhythmias may point to the precipitating cause. The presence of atrial fibrillation has the highest LR plus for diagnosis of heart failure. However, new T wave changes were also associated with the diagnosis. The most widely investigated markers, one of them has already been mentioned earlier, which are natriuretic peptides. There are also other novel biomarkers such as ST2, galectin-3, and neutrophil gelatinase associated lipopalette, but their role is not exactly established yet. Natriuretic peptide tests may add value in the setting of undifferentiated dyspnea, improving diagnostic discrimination in a variety of settings, and correlating with cardiac filling pressures. As a result, B-type natriuretic peptide testing is recommended and helpful when the cause of dyspnea is unclear after standard evaluation. Despite the established value of natriuretic peptide testing, there are many situations where interpretation of results is unclear because levels could be affected by age, gender, and body mass, and may elevate later in patients who present with flash pulmonary edema. Dyspnea and modest B-type natriuretic peptide elevation are evident in conditions such as pulmonary hypertension, pulmonary embolism, pneumonia, sepsis, and renal failure. B-type natriuretic peptide and terminal B-type natriuretic peptide testing is best used when diagnostic uncertainty exists as an addition to the physician assessment rather than as a routine measure. So generally speaking, when it comes to BNP, the low cut point to rule out heart failure is 100 picograms per milliliter, and the high cut point where heart failure is likely is 500 picograms per milliliter. For N-terminal pro-BNP, low cut point is 300 picograms per milliliter, and the high cut point for patients less than 50 years old is 450 picograms per milliliter, 900 picograms per milliliter if patient is 50 to 75. Point of care pulmonary or rather cardiopulmonary ultrasound can also help determine the cause of dyspnea, including cardiac tamponade, and can determine left ventricular function and volume status, but it's not a substitute for a full 2D echo. Can also address the following questions, which are there signs of pulmonary congestion? Are there signs of volume overload by measuring the size of the inferior vena cava and its collapsibility? Is the left ventricular ejection fraction low or normal? When we look at pulmonary ultrasounds, we use it for determining if pulmonary congestion is present by looking for V lines. Sonographic V lines are grained down artifacts that rise from the interface of the visceral and parietal pleura when there is swelling of the lungs interlobular septa due to lymphatic congestion, as is seen in pulmonary edema. They are the sonographic equivalent of curly V lines seen on chest radiography. More than two V lines in any one sonographic window along the anterior and anterolateral chest are pathologic and highly specific for alveolar and interstitial edema. However, bilateral V lines may also be present in other conditions not caused by pulmonary edema, such as fibrosis, pulmonary contusion, bilateral pneumonia, so rapid assessment for elevated central venous pressure as a marker of right heart congestion is needed in this case. An inferior vena cava size greater than 2 centimeters or a collapsibility index of less than 50% is indicative of elevated central venous pressure. In the absence of significant pulmonary disease, these measures are highly correlated with pulmonary capillary wedge pressure and are specific for acute heart failure. So pulmonary capillary wedge pressure is something we look at for acute heart failure, especially when it comes to therapy, because a lot of pharmacology involving acute heart failure acts specifically on reducing the wedge pressure. Determination of left ventricular ejection fraction is the final piece of ultrasonography. So when it comes to looking at bedside ultrasound for the pulmonary system, a bilateral B-line count of greater than 10 or more than 2 B plus zones in both lungs means that acute heart failure is likely. And if we suspect that there's acute heart failure, we check if there's HFpEF or HFrEF. So basically preserved ejection fraction or reduced ejection fraction. So the cutoff for this is left ventricular ejection fraction of greater than 50 means it's likely preserved, less than 50 reduced. So when the bilateral B-line count does not fit this parameter, which is basically greater than 10 or more than 2 zones in both lungs, we look at an inferior vena cava of greater than 2 centimeters with less than 50% collapse. If that's positive, then we see evidence of acute right ventricular strain. But if we don't see an increase in the caliber of the inferior vena cava, obtaining BNP levels may be prudent if available. So the initial approach to treatment is driven by acuity at presentation, hemodynamics, and volume status. In critically ill patients, of course, we prioritize airway management to ensure adequate oxygenation and ventilation. However, in those who are less acutely ill, we do a more focused evaluation. Supplemental oxygen use is guided by pulse oximetry, seeking saturations above 95%. Hypoxemia is a greater risk than hypothermia, so we do not withhold oxygen even when there is concern about carbon dioxide retention. Pacnometry and arterial blood gas measurements can help titrate therapy in the critically ill or if carbon dioxide retention is likely. So in those with extreme findings, endotracheal intubation with mechanical ventilation is indicated. Non-invasive ventilation may improve the symptoms in patients presenting with heart failure or pulmonary edema. Successful non-invasive ventilation requires close monitoring, hemodynamic stability, and facial anatomy that allows an adequate face mask seal, and patient cooperation. So using either a face mask or nasal device, non-invasive ventilation can be delivered with continuous positive airway pressure throughout the respiratory cycle or with bilevel positive airway pressure. Non-invasive ventilation plus standard medical therapy reduces the need for intubation and improves respiratory distress and metabolic disturbances versus standard therapy alone. Acute heart failure with hypotension occurs in approximately 3% of patients. We consider acute coronary syndrome, and management may require reperfusion therapy. Treatment includes the initiation of inotropics such as norepinephrine, dopamine, or dobutamine, or admission to the ICU. So when it comes to hypertensive acute heart failure, the failing heart is sensitive to increases in afterload, with some patients developing pulmonary edema with a systolic blood pressure of as low as 150 millimeters mercury. Prompt recognition and afterload reduction with vasodilators can avoid the need for intubation. So we have a stepwise approach to the management of hypertensive heart failure. Administer oxygen as needed for saturation greater than or equal to 95% and give sublingual nitroglycerin. Sublingual nitroglycerin may be repeated up to 1 per minute. If there's severe dyspnea, we consider non-invasive ventilation or intubation. If the blood pressure is greater than 150 over 100 millimeters mercury, we add intravenous nitroglycerin or nitroprusside. If the blood pressure falls below 100 millimeters mercury, we stop nitrates and monitor for persistent hypotension or symptoms. If the blood pressure is less than 150 over 110 millimeters mercury after sublingual administration and if improved, we consider transdermal nitroglycerin. We start IV loop diuretics like furosemide in the setting of volume overload, but we have to initiate the nitrates before the diuretics first. We assess for severity of illness or high risk, altered mental status, persistent hypoxia despite non-invasive ventilation, hypotension, troponin elevation, ischemic ECG changes, blood urea nitrogen of greater than 43, creatinine of greater than 2.75, tachycardia, tachypnea, or inadequate urine output. ICU admission may be needed if there's a high severity of illness or a risk of decompensation. Nitroglycerin is a short-acting, rapid-onset systemic venous and arterial dilator. It decreases mean arterial pressure by reducing preload and at high doses initially after load. This is because nitroglycerin is mostly a vasodilator for the veins at normal doses, but in higher doses, it increases arterial vasodilation. So this can decrease myocardial ischemia and improve cardiac function. The route chosen, IV, sublingual, or transdermal, is based on the severity of symptoms. Sublingual nitroglycerin is very easily administered, rapidly bioavailable, and can be given as often as needed to reach a desired clinical endpoint, provided that there is adequate blood pressure. An initial approach is repeated sublingual administration of 0.4 milligrams nitroglycerin at a rate of up to 1 per minute until relief or replacement with IV nitroglycerin. When using the latter, which is IV nitroglycerin for most symptomatic patients, a starting dose of 0.5 to 0.7 micrograms per kilogram per minute is common and titrated every few minutes up to 200 micrograms per minute based on the blood pressure, so we avoid large drops in symptoms. High doses may be beneficial in the acute settings, but adverse effects, or rather adverse events, are uncommon. We apply transdermal nitroglycerin 0.5 to 2 inches to the chest wall based on blood pressure only after initial therapy has improved conditions or symptoms are minor because this has a very slow onset of action. The most important nitroglycerin complication is hypotension, which is transient and at times even seen with overall clinical improvement. Hypotension usually resolves after cessation of nitroglycerin. If persistent, we think of concomitant volume depletion or right ventricular infarct and deliver a normal saline fluid bolus of 250 to 1,000 ml rather. Headache is frequent, but paracetamol usually is adequate therapy. Methemoglobinemia is a theoretic possibility, but not a concern unless high doses are used for extended intervals. Despite broad uptake into regular clinical practice, nitroglycerin has been subject to little prospective study. So there's also nitroprusside, which we use further after load reduction is required. such as if there's continued high systemic vascular resistance, manifested by persistent elevated blood pressure and continued symptoms despite nitroglycerin doses of greater than 200 micrograms per ml. This drug is a more potent arterial vasodilator than nitroglycerin, and its hemodynamic effects include decreases in blood pressure, left ventricular filling pressure reduction, and an increase in cardiac output. The initial dose of nitroprusside is zero point 0.3 micrograms per kilogram per minute, titrated upward every 5 to 10 minutes based on blood pressure and clinical response, with a maximum of 10 micrograms per kilogram per minute. The major complication is hypotension. It is also associated with biocyanate toxicity, especially with high doses, prolonged use, and hepatic or renal impairment, which is why we don't use it in those patients. The critical endpoint is rapidly lowering filling pressure to prevent the need for endotracheal intubation. We give intravenous vasodilators as soon as vascular access is established if the blood pressure remains elevated. After vasodilator therapy, some patients may require diuretics based on continued symptoms after blood pressure is controlled. Furosemide is most commonly used because it is a diuretic, usually administered alone without vasodilators for hypertensive heart failure, and it may increase mortality in this case and worsen renal dysfunction. So it's better to give them with vasodilators. Ultimately, successful management of blood pressure and cardiac filling pressure creates marked improvements in respiratory status long before any diuresis. Contraindications and alternatives to vasodilation in select settings include flow-limiting, preload-dependent states such as right ventricular infarction, aortic stenosis, hypertrophic obstructive cardiomyopathy, or volume depletion, because these increase the risk of vasodilator-associated hypotension. So we don't use it in patients with signs of hypoperfusion or existing hypotension. Combined with acute pulmonary edema, the latter preload-dependent states are very difficult to manage. Therapy is aimed at decreasing the outflow gradient by slowing heart rate and cardiac contractility. Although this can be established with intravenous beta blockers, treatment is best done in the intensive care unit with invasive hemodynamic methods. If there's coexistent shock in the setting of hypertrophic obstructive cardiomyopathy, phenylephrine at 40 to 100 micrograms per minute via IV is a good choice because it creates peripheral vasoconstriction without increasing cardiac contractility. So for normotensive heart failure, shortness of breath, orthopnea, jugular venous distension, drills, and possibly an S3 sound may still be evident even in the presence of normal vital signs, oxygenation, and ventilation. So in this situation, we treat with diuresis first, with further treatment based on response to therapy. Loop diuretics like furosemide provide rapid symptomatic relief of congestive symptoms and improve the effects of angiotensin-converting enzyme inhibitors by decreasing intravascular volume. Most patients require intravenous dosing because bowel wall edema may prevent proper gastrointestinal absorption. Dosing is guided by symptoms and prior usage. In general, those loop diuretics have the lowest possible dose that relieves congestion. Once congestion is resolved, a fixed maintenance dose is continued to prevent recurrence. Loop diuretics promote water and sodium excretion and are effective except in severe renal dysfunction. Furosemide is inexpensive and effective. Alternatives include torsemide, not sure if that's available in our setting. And all of these trigger rapid diuresis after an IV dose, often within 10 to 15 minutes. So causes of hypotension after vasodilator use include excessive vasodilation, hypertrophic obstructive cardiomyopathy, intravascular volume depletion, right ventricular infarction, cardiogenic shock or myocardial infarction, aortic stenosis, anaphylaxis, and unsuspected sepsis. So vasodilators that we have are sublingual nitroglycerin, IV nitroglycerin, nitroprusside. Titration endpoint for both of these are blood pressure and symptoms. Complications are hypotension, and for nitroprusside, we have cyanide or thiocyanate toxicity and coronary steal. For heart failure diuretics, we have furosemide. If the patient has never used it before, we give it at 20 to 40 milligrams venous push. Diuresis starts within 15 to 20 minutes. There is possibility of hypokalemia, hypomagnesemia, hyperuricemia, and hypovolemia. If the patient has used it before, total daily intravenous dose, 1 to 2.5 times the patient's previous total daily oral dose, divided in half and given intravenously via bolus every 12 hours. The duration of action is 4 to 6 hours, and complications include ototoxicity and prerenal azotemia. The dose trial suggests that the total daily IV dose, 1 to 2.5 times the patient's previous total daily oral dose of furosemide, divided in half and administered by IV bolus every 12 hours is prudent to use. So if the patient has been on furosemide 80 milligrams per RM twice a day, then an initial emergency dose is 80 to 200 milligrams IV bolus. Higher doses are associated with more rapid symptom improvement, but a slight decrease in renal function. So for patients who have never used loop diuretics before, again, we could use 20 to 40 milligrams per IV. Diuretics may worsen renal function, create hypokalemia, and an increasing QT interval should trigger a search for hypocalcemia, hypokalemia, or hypomagnesemia. Ototoxicity, as mentioned earlier, is a rare complication, but it may occur if diuretics are used in conjunction with aminoglycoside antibiotics. Spironolactone, a potassium-sparing diuretic, is reserved for more advanced chronic heart failure, and they're used more for their mortality benefit than for a diuretic effect. So other treatments include ultrafiltration, which allows the extracorporeal removal of plasma water from pool blood across a semi-permeable membrane with a transmembrane pressure gradient. Ultrafiltration has advantages over diuresis, including more precise regulation of fluid removal, avoidance of diuretic-associated electrolyte abnormalities, and a higher level of sodium removal for a given amount of volume, and attenuation of significant fluctuations in intravascular volume. While initial studies provided promising safety and efficacy data, subsequent study in patients with cardiorenal syndrome and persistent congestion did not demonstrate an advantage of ultrafiltration over bolus diuretic therapy. We can consider it if all diuretic and medical strategies are unsuccessful for patients with obvious volume overload to alleviate congestive symptoms and excess. Morphine at 2 to 5 milligrams intravenously relieves congestion and anxiety, but there are many adverse events that may occur, such as the need for mechanical ventilation due to respiratory depression, prolonged hospitalization, ICU admission, and mortality. If it is desired for its venodilation properties or pain control, it is used in small titrated doses with close monitoring. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are given for hypertension and chronic heart failure, but there's little data to recommend use in the emergency room for acute heart failure. Oral angiotensin-converting enzyme inhibitors decrease mortality and hospitalizations in patients with reduced ejection fraction, and these are often used after observation care if there are no contraindications that exist after contact with a primary care physician or cardiologist. So ACE, or rather, ARBs are alternatives to or can be added in select heart failure patients with reduced ejection fraction. They may also be considered after consultation and completion of treatment. So there's a possibility that they can precipitate angioedema, especially angiotensin-converting enzyme inhibitors. Beta blockers are not usually initiated in acute heart failure except to control rate-related heart failure. They are generally reserved for stable patients. The rationale for beta blockers rests on the fact that norepinephrine levels are elevated in heart failure, contribute to myocardial hypertrophy, increase afterload, and coronary vasoconstriction, and are associated with mortality. Beta blockers reduce sympathetic nervous system activity and are used for mortality reduction and symptom relief. So there are drugs that we avoid in acute heart failure, such as calcium channel blockers, especially oral ones, because they have myocardial depressant activity and they are not beneficial or may cause worse outcomes for these patients. Amlodipine may be used for compelling clinical reasons, such as an anti-anginal agent despite maximal therapy with nitrates and beta blockers. We also avoid non-steroidal anti-inflammatory drugs, whether they are selective or non-selective in patients with acute heart failure, because they can cause sodium and water retention and blunt the effects of diuretics and may increase morbidity and mortality. And that's it. Thank you so much for listening.